Good afternoon, all. First of all, I thank the organizers for the invitation to Suriname to present something about its the HIV situation. Sorry. So this is Suriname. It is a country on the northern part of South America. It has just over 500,000 inhabitants, and HIV prevalence in the country is between 1% and 2%. We have about 500 new cases of HIV per year, and the total of cases is currently at about 5,000. There's an equal distribution between men and women, and the mortality has been going down for quite a few years now, probably due to the availability of antiretroviral therapy. So these are the cases since 2006, and we see that since about 2010, we are at about 600 new cases, newly diagnosed cases per year. Unfortunately, there's a significant number of patients that is diagnosed late. I think about over 40% comes in with a CD4 count of about 350, but almost 30% has a CD4 count of lower than 200. Most of the time, these people are symptomatic, and that is often the reason why they come into the system. Okay, we have a poor coverage of antiretroviral therapy. In this figure is included the people who are not diagnosed, but who are assumed to be HIV positive. It's just at 50%. Annually, we enroll about 500 new people in antiretroviral therapy, and most of them will probably be the patients who are just presenting with symptomatic HIV infection. This is to show where we are with regards to the 1990 target. We're not doing very well in the people who know their status, just over 60%, but the percent of people who know their status and who are on ART is almost 80%, and in 2017 we had more than 80% of viral suppression in those on ART. This is a figure that comes from the UNAIDS website. It's based on data that have been provided by our government. What I'm missing is the data about retention in care, because that was a specific item for this meeting. But fortunately, at the academic hospital where I work, and we have about 2,000 patients in care, earlier this year we did an analysis of how the patients that were linked to our care center are doing. And we found that almost 35% of the patients who were linked to care in our hospital were not retained in care, but but most of the ones who were retained in care were on ART, 90%, and of those, 85% was virally suppressed. So the biggest problem, especially in the population being serviced at the academic hospital, is retention in care. That is something that we are not doing very well. So can we do better to retain people in care? In order to investigate that, we have called this year about 60 patients who have missed at least 2 visits, and that is about who didn't show up for 6 months. And one of the things that we met is that almost half of these people could no longer be reached by phone. They didn't pick up. 10 claimed insurance issues, which I come to later. This is not always true because the treatment is free, and our social workers always help you to get insurance if you don't have it. So we consider these people also as people who don't really want to come back to the clinic. We were only successful in getting 3 patients to re-enter care. And this shows that there is quite a high rate of reluctance to be on care in an HIV clinic. And there are several reasons that we could identify. There is poor self-acceptance. In Suriname, there's a high rate of people who insist that antiretroviral therapy is not for them. They have alternative ways of being treated. And what particularly seems to be annoying them is that they do not want to go to a continuous medication for the rest of their life. That's something that some people tell you when you inform them. They say, but Dr. Buddha, I have to take this medication for the rest of my life, and I can't give them a negative answer. Stigma, of course, is also very important, and fear of being abandoned by family or friends, but that is not something new. Okay, but on the healthcare provider side, there are also some things that are not really in place. I think that we would need more staff dedicated to tracking patients who do not come back to the clinic, because we do not have enough staff to continuously do that. I think, and we are considering that currently, we should try to move to a less vulnerable first-line regimen, so that people who are not optimally adherent in the beginning can still continue on the same medication after additional counseling. We do not have genotyping currently. Our university is busy in setting up a system, but that will not be it, because doing it yourself in the old-fashioned way is extremely expensive. So there should be another way to getting genotyping, because in several patients it's not the second line that we are concerned of, but it's in how to create an effective third line. And then you really might need genotyping, because most of these people have been taking medication on and off. And innovative health promotion, not specifically for people, to prevent people to get infected, but also on how to behave once you have been diagnosed HIV positive. On the legislative side, there are also some problems. Unfortunately, I don't know if this is the case in all the country, but unfortunately, employers are still quite often requesting an HIV test. And if you are HIV positive, you will not be hired. This is really a problem in Suriname. And we need to improve or provide access to health for uninsured and undocumented people. We have quite some undocumented people from Brazil, from Haiti, from Guyana, from several countries. And most of the times these people are undocumented. And if you're undocumented, you cannot get health insurance, and that is a problem. Okay, and then with regards to TB and HIV, Suriname has about 150 cases of TB annually, and about 27% of these cases is co-infected with HIV. There's pulmonary and extrapulmonary tuberculosis. This is higher in the HIV positive population. But what we see is that most patients who have TB and HIV have either relatively low CD4 count at diagnosis, or are diagnosed for being HIV positive at the time of the TB diagnosis. This says something about the usefulness of IPT in our society. Probably most of these people would not have benefited from ITP because they were just not on our radar. So the mortality, of course, of TB and HIV co-infection is almost 3 times higher than in uninfected, non-HIV infected TB patients. And of course, a lower CD4 is also, gives also a worse outcome. So far for TB. And finally, a few slides over pre-exposure prophylaxis. We are having pre-exposure prophylaxis for a few groups of people. I called it conceiving discordant couples with cold feet, because we always advise that people should be using, should be virally suppressed before they start conceiving. But then, even when this happens, the negative partner may, well, have cold feet, still does not want unprotected sex. Although we say, in fact, undetectable is untransmittable. But in these cases, we just give Truvada to this negative partner. We also promote surgeons to use PrEP if they have to do an emergency operation in virally unsuppressed patients. And it gives them a feeling of security rather than postponing the operation. we have not yet promoted PrEP for the general population, and there are a few reasons for that. One of the things is, this is a slide from our microbiology lab, showing that the proportion of positive syphilis tests is increasing since 2016. We have concluded this shows that HIV is, syphilis is on the rise in Suriname, and that can be interpreted positively for PrEP, saying that yes, then you need PrEP because then you know that there's a lot of unprotected sex. But it may also be interpreted as well, if you are going to introduce PrEP on top of this, then really your syphilis rates will go up. I don't know, but we have to make a decision on that. But there are a few other things with regards to PrEP. I think it's very important that the target population is well informed and well motivated to take PrEP and take it in an adherent way. Otherwise, it may only lead to further primary resistance in patients, and that is something that you don't want in a setting where you have limited treatment options. I think that if you would be introducing PrEP, you would also want to have genotyping present, because especially for late presenters, because PrEP may increase the number of cases with the primary resistance, and people coming in with a very low CD4 count. You would like to start a therapy that is effective, and that could only be done in such a situation if you could do genotyping very early in the treatment. And then finally, the government of Suriname has so far not decided whether they would finance PrEP or not, so we have to wait for that decision. I think this concludes the presentation of HIV in Suriname, and I wonder if you have any questions. Thank you.